Afternoon, and thank you for coming to our lunch with a legend. Our legend today is Dr. Bartlett. Welcome, Dr. Bartlett.
Thank you, Jeff.
It's great to have you here. I think our audience today is going to find our session inspirational and something they'll remember for a while. And of course, ECMO is a very hot topic right now, so it's relevant. We're going to talk about a little bit about you here at first, and if we say something that's not accurate, please correct us. You went to college in Michigan, but you spent your formative years in Ohio, right?
That's right, Akron, Ohio.
So I think you're an example of one of those excellent Ohio youths who somehow found their way to Michigan by accident.
Oh, that's great. Thank you.
Did you find your way to Michigan by accident out of Ohio?
Actually, I knew I wanted to go to the University of Michigan Medical School.
Okay.
And so I got the catalog that said where all the med students came from. Most of them came from the University of Michigan, but the next most common place was Albion College. So I went to Albion College.
It's a small college, right?
Small college, and I was looking for a place where I could play music and play hockey, and I knew I wouldn't make the varsity at Michigan, so I went to a small school.
Great.
So you obtained your medical degree from the University of Michigan Medical School, cum laude, in 1963, and you completed your internship and residency in surgery at the Peter Bent Brigham Hospital in Boston from 63 to 67.
Right, a hospital that no longer exists, or it morphed into the Brigham and Women's Hospital. There's an interesting story that goes with that, but I won't tell it right now.
So what we're looking at here, this is Francis Moore, professor at the previous Peter Bent Brigham Hospital. Did he have much of an influence over the course of your career?
Had a huge influence. So my two chiefs were Franny Moore and Robert E. Gross at the Children's, and they're arguably among the most important surgeons of the last century. Franny Moore is credited with bringing a lot of science into surgery. He studied especially the response to trauma, but developed all the research on fluids, electrolytes, endothelial barriers, and metabolism and nutrition and all that sort of stuff. It was a wonderful place, and he's a very good surgeon.
So you also trained under Robert Gross at Boston Children's Hospital.
I did. So the Brigham residency in those days was a 6-year residency, which included everything that was surgical. So we spent a full year at the Children's Hospital doing pediatric surgery, and the residency qualified us to take boards in general surgery and cardiothoracic surgery. This was before there were separate boards in pediatric surgery and intensive care and things like that.
Those that remember Dr. Gross knew him as for his meticulousness in all things.
Yes, that was at a time when cardiac surgery was just being developed, very early days. Remember the first case that Gibbon did was in 1954, and it grew very slowly after that for a variety of reasons, but most of it was in children because what you could do is repair congenital defects, ASDs and VSDs. So there wasn't much of a reason to be operating on adults with cardiac failure, and Gross was meticulous, is a good description, masterful surgeon. You all work with a variety of surgeons. Every now and then there's one surgeon who things just happen. They just happen perfectly. The operation doesn't take long. If you know one of those people, you're very lucky, and Gross was like that. But the chief of thoracic surgery at the Brigham Hospital was Dwight Harkin. I don't think there's anyone here who knew Dwight Harkin, but if you could imagine the exact opposite of Robert E. Gross, that was Dwight Harkin. Bombastic, hardly meticulous, but he invented the mitral valvuloplasty, or the closed mitral operation. When I was a resident, we would do 3 a day of closed mitrals, that is to say, off bypass. We did cases on bypass as well, but basically all aortic valve disease. And so the experiences in the two hospitals was very different. I should say that the perfusionists in those hospitals were, of course, not what you would call perfusionists today. So what you did as a cardiac surgeon when you're developing it was you got someone who was just very competent, very confident, and taught them how to run the pump. Usually the best circulating nurse in the OR, and that's what was the case at the Brigham and the Children's. The perfusionist at the Brigham was Scotty Fosberg. She should be a legend somewhere. And at the Children's was Jean Lutz, who was a classy, marvelous, elegant woman, and she ran the pump. That had more than a little to do with how I got involved with the development of ECMO later on.
So was it at Children's what first sparked your interest in ECMO?
It was. So we didn't set out to do what you'd now call ECMO. What happened was that for complex operations like tetralogies and we weren't doing transpositions, but TETs and complicated procedures, the mortality was about 50%. Half the children died. And the reason was because of the heart-lung machine. Bob showed us at the beginning of this meeting, so those early heart-lung machines, but the method of oxygenating the blood and removing CO2 was just to expose the blood to raw 100% oxygen, either through a screen system or rotating discs, so there were lots of ways to do it. But if you kept that up for more than about an hour, it severely damaged all the formed elements of the blood and the proteins. And if you kept it up for 2 hours, it was a lethal instrument. When that was just the standard, the way it was. So each time you did a cardiac case, which was every day in those days, then you had to take that entire system, put it in a big sink, clean it out, wash every disc in the 116 discs oxygenator, wash every one of the about 400 channels in the big Brunswick heat exchanger if you were doing deep hypothermia. So someone had to clean the pump and reassemble it, and of course that was Jean's job, but she didn't have a few hours to spend doing that, getting ready for the next day. So Dr. Gross learned that if he hired a resident's wife, then that person was probably an intelligent person, probably be careful about what they were doing, and could clean and reassemble the heart-lung machine. So our rotations at the Children's were 1 year long, and the guy who was leaving said, "What does your wife do?" He said, "Well, she's a teacher, and she's home taking care of a kid." He said, "That'd be great. If you'd like, I'll put the word in to Jean and Dr. Gross to see if your wife would like this job of coming in and cleaning the pump in the afternoon." So I volunteered her for that. So of course, she did that. So every day, well, my wife Wanda would come in, and the sink would be full of the heart-lung machine. It would take it all apart, and all the connectors were metal, if you can imagine that. All the oxygenator was, in that case, usually a disc oxygenator. It was a roller pump, so you had to find new Tygon to put into it. And she would assemble the pump. It took a few hours, and then put it into the walk-in sterilizer for the next day. And she didn't know anything about surgery or the OR or whatever, but she, of course, was careful to do a good job at all that. And in the process, she got to know Jean Lutz very well because they worked together every day. Paid $4 a pump. It was really a big deal in those days.
It's a lot, yeah.
It was a lot.
And through Jean connection, we got to know Dr. Gross a lot better than most of the other residents. He was meticulous, but also pretty reserved. You didn't speak to Dr. Gross unless he spoke to you, that sort of thing. But we got to know them quite well, and so I had the temerity to go to Dr. Gross and say, why is our mortality so high? It just seems to be the longer you're on bypass, the higher the mortality with renal failure, heart failure, brain failure. You all know what that syndrome is like, the SIRS syndrome, which we didn't call it that at the time. So I said, why don't we just keep these kids on the heart-lung machine for a couple of days? And we all knew that if they got through that first 24 hours, they'd be fine, they'd recover. He said, well, you can't do that. The machine is the reason that they're dying, but why don't you work on that? So I've been working on that ever since.
That's right.
So at that time, this is in the 60s, silicone rubber had just been discovered a few years before, and as you all know, it has unique properties as a plastic as it transfers respiratory gases rather than block them like saran wrap or something.
We're going to ask you about that in a few minutes.
Okay, good.
You brought up Dwight Harkin. I'm so old, I had the privilege of working on a video project with him after he was legally blind. And one of his themes was the pain of the pioneer. The pain of the pioneer. I'm sure you heard him say that. You were involved with landmark cases. Do you want to discuss Lorraine Sweeney? Do you remember her?
I did meet her at one time. She was the first successful ductus ligation, and that really formed the basis for all of cardiac surgery in children and eventually in everybody else. And Gross was the one who operated on her after a lot of other people had tried that operation and had it fail. So she, as the first ever case, was important, and she lived in the Boston area, so she would come back periodically to gatherings, and here's a picture of Dr. Gross with her many years later. At the time, she was about 4 years old.
We're going to talk in more detail about Esperanza later, but you want to comment on how you met her and
Well, Esperanza Pineda is the first successful newborn patient, was on ECMO. So by this time I was in California. We'd been working on membrane oxygenators for about 10 years, starting in '65. And in 1975, this little girl was born at the Orange County Medical Center in profound respiratory failure at the time. And the neonatologist said, how's that thing working in the lab? Why don't you bring it over here? Hook it up to this patient. So we did. And her story was interesting. We didn't really know what to expect, but actually she recovered after about a week on what we would now call ECMO and VA bypass with a membrane oxygenator. And that particular group of patients, newborn infants with respiratory failure, turned out to be very important because that technology worked really well in those patients, whereas at the time it didn't work well at all for adults or cardiac failure.
Nice.
So we found this picture here. This was from the Boston Children's Hospital surgery staff in 1965. Can you tell us about this photo? And is that you in the back center?
Yes, I'm in the middle of the back row there. And Dr. Gross is in the middle of the front row. You can look at that picture and imagine what his personality is like. And he was wonderful, a marvelous person in every way, but very humble, and but absolutely in charge of whatever went on. So the other staff members are in the front row. A series of senior residents or fellows are in the middle row. People came from everywhere to see what pediatric cardiac surgery was like. And then the more junior residents are in the back row. So that was quite a long time ago, but on the far left in this picture is Dave Murphy, became the pediatric and cardiac surgeon in Halifax, Nova Scotia for his whole life. The next is Hugh Watts, he became an orthopod. The next is me. The next is Arnie Koren. We were residents together, and he became the chief of pediatric surgery at the University of Michigan, actually, in later years, and we remain great friends. The next is Tom Putnam, and the next is Al Gazzaniga. So if you're from Orange County, California, you know about Al.
Amazing.
So this is a monograph about the history of Boston Children's, and this is a quote from it. "There is a long golden cord that stretches from lad to the present, binding all of us together as in no other surgical specialty." We added you here at the end. It mentioned Ladd and Gross. What is the golden cord?
Well, Ladd and Gross were the important ones. I don't deserve to be on that list. William Ladd was really the first pediatric surgeon, probably in the world, certainly in the United States, and he was the chief of surgery at the Children's Hospital at a time when very little surgery was done for children. But he developed that field, and then Gross was originally his trainee and then his successor. And it is true that almost everyone practicing pediatric surgery, including pediatric cardiac surgery, can trace their roots back to Ladd and Gross. So that's what it's about. If you're interested in that particular field, Phil Glick, who is a pediatric surgeon, I think in Buffalo or SUNY somewhere, published a book tracking that exact lineage. So it is interesting to see that basically everybody who calls himself a pediatric surgeon, or someone like me who did a lot of pediatric surgery, but I don't call myself a pediatric surgeon, traces back to those people.
You've earned several awards and recognition by your peers. Back in 2002, the American Surgical Association, the Medallion for Scientific Achievement, 2003, the American Academy of Pediatrics, and of course, our John H. Gibbon Jr. Award here at AmSect back in 1994. We didn't want to put your 800-page resume up on the screen, but I do want to refer to my notes and talk about some highlights. I think our education and our preparation is an award in itself and a privilege. We talked about Albion. We talked about the University of Michigan. Did you go through medical school in 3 years?
No.
Oh, okay.
I went through it 4 years, but I was at Albion for 3 years. At those days, many colleges, including Albion, had an arrangement with medical schools where you could spend 3 years in undergrad and 4 years in med school, and they gave you credit for your med school to graduate from the college.
Perfect. You did your residency at Peter Ben Brigham in 63 through 67, including a fellowship, 68 through 69. You were the chief resident in thoracic surgery at the Brigham. And then at the same time, those last 4 years, 66 through 70, you were an NIH trainee in academic surgery at Harvard Medical School, and then 68 and 69, a Harvey Cushing Fellow in surgery at Harvard. That was a lot.
Wow.
And believe me, in those days, it was just being a resident. That's what you did.
Yeah, but I think you earned a great residency, and a great fellowship, and a great educational opportunity.
Great people, yeah.
And why did you go to California? 17, 18.
When I finished residency and actually spent a year on the staff as a young guy at the Brigham, one of my fellow resident buddies, Al Gazzaniga, that I mentioned earlier, was from California, and he wanted to go back to California and took a job at a brand new medical school, University of California at Irvine, which literally was a brand new med school. So he said, why don't you come out and take a look at this place? And so I did, and decided to take the job. So Al and I ran a whole lot of surgical practice, and the chief was a guy named Jack Connolly, who was recruiting people who were general and thoracic and cardiac boarded, who could also do pediatric surgery and vascular surgery and trauma. So we did all of that stuff. So it was really an exciting time. I was there for 10 years.
You went through the ranks, the academic ranks in 7 years to full professor.
I did.
1977. And then you returned back to Michigan in 1980. What drew you back to Michigan from California?
After about 10 years at UC Irvine, my research was going quite well. and well-funded and so on. And it was clear that UCI is a great med school for GPs, but it was never going to be in the big leagues from a research institution. So I actively decided to leave in 1980 and had several good options, but decided to return to Michigan, which for me was a great choice.
So I want to ask you an important question here. How do you want us to remember your legacy, or how do you want your legacy remembered and all that?
Well, it's a good question, but I just took care of sick patients one after another. That's what I did. Is there a legacy attached to it? Well, perhaps. I mean, you're getting involved with the ECMO business, but my major contributions are really in the field of intensive care. ECMO is just a little niche of that particular career.
So Dr. Hill's early paper on ECMO was reported in 1972 in the New England Journal of Medicine, and it was a success for an adult trauma patient in Santa Barbara. I'm told you actually were consulted on this case. Can you tell us a little about that?
Yes, well, many of you probably, if you're from San Francisco, you know Don Hill, wonderful guy, cardiac surgeon. We're about the same age. And Tom O'Brien, who's the second author here, was a general and thoracic surgeon in a little hospital in Santa Barbara, the Cottage Hospital, as a matter of fact. And, but we knew Tom from residency days, and we stayed in touch. So he had a patient, the patient described here, who was in a motorcycle accident, had a lot of injuries, including a ruptured thoracic aorta. Tom operated on him and fixed all of his problems, did a great job, but he wound up in what we'd call severe ARDS the next day. So he called us up, Al Gazaniga and I, said, "You guys still working on that machine thing? I've got this patient here who's dying, needs to go on bypass. What do you think?" I said, "Well, we're working on it, but we're not ready yet." However, Don Hill in San Francisco, not too far away, had already done 6 cases in adults, VA bypass for ARDS, basically, and all without success, but nonetheless had been doing it. So we called Don, said, "Would you come down to Santa Barbara, think about hooking up this patient?" So he came down with Maury Bramson, who's listed here, who was his engineer, and his perfusionist, Angelo Iatrides. I see he's not on the list of authors. And brought his machine down and hooked it up, and patient was on, not for very long, just 2 or 3 days, and patient recovered. So I had some connection with this particular case, and then we went on from there, and of course we all became good friends and all worked on this together.
Was one of your contributions anticoagulation to that case?
Well, yes. When we first built a membrane oxygenator, this was back in 65, 66, and I was back at the Brigham and working with the engineer whose name was Phil Drinker, who from MIT, but had a lot to do with this. So we built a membrane oxygenator, and what do you know, it worked, and then we improved it, but of course, you had to anticoagulate the blood. So we're using dogs at that time, and if they got on the machine at all, they simply bled to death. So and like all of you, perfusionists, you just give pounds of heparin because you can always reverse it at the end of the case. But we were doing this for hours and then days at a time. We couldn't tolerate the bleeding. So we learned to titrate down the dose of heparin to a dose which prevented clotting in the devices, but usually prevented bleeding in the patients. So that was the beginning. We built a little machine to measure how long it took the blood to clot. That became the ACT machine. I have no patents on any of this. I wish I did. But so we began, so we learned that you had to keep the activated clotting time about 1.5 times normal. The way we did that was you put some rabbit brain thromboplastin, that's the agent that's used for PTT, in a test tube, and then you added exactly 1 cc of blood, and then you just sat there, tilted it until it became solid and wouldn't tip anymore. So that's the way ACTs were done for the first several years of what became ECMO.
I'd like to spend a few moments talking about some of your publications. I've noticed that in your writing, you're like a novelist, and you're very thorough and packed with details, and often include a lot of predictions and guiding principles. So this paper here, is this the culmination of many years of research?
Yes, but this was the first clinical paper that we published, I think. Yeah, there are 6 patients, only one of whom survived. So well, we thought it was important to record what we were doing, and Don Hill had reported that case with success. But this paper was important because our case right after Don Hill's case was a little boy that we had done a mustard procedure for transposition. Anybody remember a mustard procedure? And was in cardiac failure post-op. And so we hooked up our machine and he recovered after a short run on bypass. So you can see these are mostly adults, a couple of children, but all died as we're learning how to do this, except the one patient on there, Eddie Albrecht, was patient number 3 who recovered. So that was really the first ever ECMO for cardiac failure that's been reported.
So on the ECMO team, we would say this, we had 1 survivor. We wouldn't say we lost 5. But, the world experience at the time was about 72 patients had been reported on ECMO with 11 survivors, 72 on, 11 survivors.
Right.
Gibbon gave up after 4 of his first 5 patients didn't make it. Why did you and others keep going?
Well, the concept is pretty simple. If you could just keep someone on bypass for days at a time, then you could at least make a diagnosis, maybe do some treatment, and maybe they'd get better. So that was what we were shooting for. And this little boy, who's a 2-year-old, recovered. So we said, well, this is going to work. And then a couple of years later, we tried this on neonates before, but the first neonate who recovered and survived was Esperanza that you saw earlier. And then we learned that we did a lot of other patients, but our survival rate for adults was about 20%, and for children it was about 90%. So we focused on that group of patients.
David talked about grit yesterday. It sounds like you and your associates had a lot of grit.
Grit, well, maybe we were just foolish, I don't know, but we kept at it because it was working. And again, people nowadays say, did you ever imagine how this would grow, and was that the idea? We're just taking care of one sick patient after another. Here's something to do that was beyond conventional intensive care at the time.
So as we read through this paper, and you just alluded to it, this is an excerpt from that paper. Were you concerned that we might be opening Pandora's box here, unleashing a technology that may be overly or improperly used?
No, not in the least, because you know, if someone's dying and you can keep them alive long enough to do something that causes them to survive, it's worth doing it.
Here's another quote from 1974 publication. We talked about patient selection now and early use of ECMO. You talked about it in 1974. Is this the Achilles heel of the therapy, or?
Well, the Achilles heel of ECMO, as you all know, if you're getting into it, is waiting too long before you institute it. So we've learned, as all of you have, that if you wait until someone's almost dead, they'll still be dead after they're on ECMO. So you have to develop some system for measuring severity of illness to say this person is now at 80-90% mortality risk. And we did a lot of that over the years, and there's several systems around for both respiratory and cardiac failure these days. But the key is to, as soon as the patient reaches that point, then you should go to ECMO support rather than trying something else and something else. You should try everything, do all that stuff, but do it all at the same time. So you have about 6 hours after being in severely ill status. That's the time to institute ECMO, whether it's respiratory or cardiac failure.
So here's a more recent publication on the volume of procedures and the odds of survival. What should be the criteria for considering a program in terms of volume?
Well, it is interesting. This is a good paper, and this comes from the registry, which now has 100,000 patients in it. We started the registry in about 1986, when there were only a few centers, and we just asked them to tell us how they did. So the registry dates back then, started by John Tomasian, a perfusionist who's been a good friend and still working with me 50 years later. So this is data from the registry, and as you might imagine, the more cases you do, the better the results are, except that if you get pretty good at this, and now you're getting good results with, let's say, newborn infants with respiratory failure, now let's see if we could use this for children with RSV infection. Okay, now the results are going to get a lot worse. And now we did that, now let's try this on adults with vaping injury. And most of those patients have ruined their lungs. So it's a hard thing to calibrate, because the centers that get really good at it are the ones that take the borderline cases that are going to have worse results. So this is all explained in the discussion of this paper, but in fact, the adult population is the only group where that correlation was significant. So and there are many centers that do 5 to 10 neonates a year. They have great results. That's all they do. And so that's plenty of cases. And there is a relationship to how many cases you do, but it's more psychological than it is scientific.
Here's a 1979 article that you contributed to our journal, the Journal of Extracorporeal Technology. And this drawing got reproduced a lot in other articles and referred to. Can you talk about the membrane oxygenator that was in this circuit in 1979?
That oxygenator was a Landé-Edwards membrane oxygenator. There were several membrane oxygenators that were built in the 70s. Only one of them turned out to be the one that we all used for a long period of time, designed by Ted Colabo, the spiral coil oxygenator that Medtronic made, or Medtronic actually bought it from a company called SciMed, but then made it, and we're so grateful to Medtronic for doing that, because that made it possible to develop this whole technology. There was really no other membrane oxygenator with a solid membrane that could be used for long-term support. So that was the Landé-Edwards, made by Edwards Labs. It was a flat sheet folded back and forth in many layers. It worked very well.
It came with salt in between the membranes, didn't it?
Well,
To separate them, or?
there was a little bit of salt in it.
A little bit.
Yeah, to keep the membranes from sticking to each other. This is silicone rubber, so it's very sticky, as you know. So you put two pieces together, they'll stick together. So there was a little salt, and so you had to flush that out before using the oxygenator.
I actually had the opportunity to use them, and we had to flush them out 2 or 3 times to get the sodium level down. It was impressive. Right. You wrote in that same article this summary statement. I'll just share this with the audience.
Well, it's true in '79 and true today.
Isn't it? That's amazing.
Tell us about the CESAR trial.
The CESAR trial was a prospective randomized trial of ECMO for adult respiratory failure that was conducted in England, or the whole UK, actually. And it was an interesting trial. There have been several prospective randomized trials of ECMO in different age groups for different indications over time. The first 2 were actually in the 70s, very badly designed, very poorly carried out, and led to the conclusion that ECMO is of no value. I can criticize it because I helped to design those trials and sat in on the long meetings at NIH when we did that study, but it was true. The lesson from that is a very complex technology like this. You shouldn't undertake a trial until you understand the technology, and that was not the case here. But CESAR came along following a prospective randomized trial in neonatal respiratory failure that was done by the same research group based in Leicester, England, and the Oxford Clinical Trials Group, which was very successful. It's an unusual way to design a trial. So think about this. This is a life support technology that you know it works, at least in a moderate number of cases. So you select people who you're quite sure are going to die, and then you randomize them to get this new treatment or not. Not means they're going to die. So to do a prospective randomized trial in which the endpoint is death has very rarely been done. The ECMO trials are really the only ones that are like that. I mean, there's never been a randomized trial of, things like penicillin or dialysis. There's no study of we're going to use dialysis or not. So that seemed obvious. But when it came to ECMO, that had to be done. So the Leicester group did the neonatal trial, which was very successful, and published it, and everyone said great, and that kind of established neonatal ECMO as standard around the world. And then they used the same study design to study ARDS in adults, and that's what this trial is about. CSER was an acronym for something. But the bottom line was the endpoint was life status at 6 months post-randomization. So you had to not only survive ECMO, but do well in life after. So the difference between the treated group and the control group was about 60% versus about 40% survival. And from my point of view, answered the question that we knew was going to be answered. The study was criticized for various reasons, but it's been repeated in a different mode by the Eolia trial. You might have read about that. The headquarters was in France with similar results.
And launched VV ECMO.
Yep.
Yes, well, we'd been doing VV ECMO since about 1980 in children and in adults. So we learned a lot about that. The original double lumen catheter was designed in our lab by Jay Zwischenberger. So someone mentioned Jay the other day, he's currently chairman at University of Kentucky.
So switching gears, you have another side to you. Can you tell us about these two novels?
Well, I got interested in writing a novel when I was writing an editorial and I couldn't get it published. So I made the argument into a novel that became the Salem Syndrome. So when I was at UC Irvine, among other things, I ran the burn unit, and it was a big burn unit, 800 burns a year. So we had a lot of experience in that field. Much like ECMO, what I learned is docs aren't very good at it, but the nurses are really good at it. So we ran a burn unit that was run by the nurses. So in that context, I got involved with a lot of expert witness cases, because there's not a lot of burn doctors around. And I got involved in a case of a man who had been convicted of child abuse by burning. He was already in prison, and the lawyer got a retrial based on some technicality, but so he asked me to look at this case. I was the first expert who ever looked at the case. It's a little girl who suffered scald burns and actually recovered, but had a lot of scars and so on. So it turns out that I was sure that this man was not the least bit guilty of inflicting these burns. Clearly it was purely an accident. But so many of you may have accomplished this. You have a kid who's below the age when they can talk, and then they sustain an injury, and the only person around is one parent or one person. And it's really easy to say, well, maybe that person did that injury to that child. So through that case, I got excited about this. I wrote editorials saying, if you're a doctor and you see a burn patient or a fracture patient, be really sure, you're pretty sure before you invoke the child abuse team, because once you invoke the team, things go into play that take hours to reverse, or days or years to reverse. So I couldn't get anyone to publish that, so I made the story into a novel. That's the Salem Syndrome. And by the time I got to the second chapter, I felt a lot better. So after that, it was just fun writing for the sake of writing. If you read that book, don't read it at night. It's really scary what happens to families that are accused of child abuse. And then I had so much fun just writing stuff that I was a philosophy major in college. I've always been fascinated by philosophy, particularly the so-called mind-body problem. So this other book is a novel about that philosophical question. The setting is a neurosurgeon who wants to find the anatomical localization of the soul, and that's how it goes from there.
That's in the heart somewhere, isn't it?
Yeah, I think so.
When are you going to write your biography?
Oh, I'm not planning on that. I don't think people would be very
Could be some scary stories in there.
There are a lot of stories, that's true.
It'd be a thriller. So, speaking of stories, students love to hear about your experience with Esperanza and that landmark case of the first successful neonatal case of ECMO. And we share with them this paper, this fascinating case report from 1975 that was published over 40 years later. Why did it take 4 decades for this paper to be published?
Well, we wrote up that case in some detail, thinking this is really important. People need to know, kind of like Don Hill's case, the first ARDS patient, and by the time we did this patient and 2 or 3 others, we knew this was going to work routinely. So I wrote it up and we sent it to several journals, mostly neonatology journals, pediatric journals. They all said, don't publish this, someone might actually do this is terrible, so we could never get it published. So we just filed it away and reported the case 3 or 4 years later, along with a dozen other neonatal cases, which finally got published. But so I was throwing stuff out and came across that original case report about this little girl. So I thought that was interesting. So we published that exact case report written in 1975, but with a lot of commentary. We published this a couple of years ago. So commentary about what the background was of that particular paper and then what we've learned since then over time. Esperanza, oh, there she is.
Who's the gentleman on the right?
It's Ted Colabo, who I often get called the father of ECMO, but Ted Colabo is really the father of ECMO. He never did a clinical case, but he was a marvelous researcher and developed the cannulas and the oxygenators and the systems that we all use all the time. So in 1989, we established ELSO, Extracorporeal Life Support Organization, and at ELSO meetings, occasionally we would invite Esperanza to come and meet all the people, because it was mostly neonatal and they all knew the story about her. So that picture was taken in, I don't know what year, this about 95, something like that.
I couldn't help but notice on the case report as I leafed through it, and looking down at the parameters that you measured during her ECMO run, and I couldn't help but notice you were monitoring oxygen delivery.
Oh yes, well it's all about oxygen kinetics. When it comes to hypoxic respiratory failure, you have to understand what the normal oxygen requirements are, and in a newborn it's 6 cc's per kilogram per minute, and then design a system that will deliver at least that much oxygen. You may not need that much, but you have to be capable of doing it. Yeah, so we worried about oxygen delivery. What you don't see on this graph is oxygen consumption, but we always manage delivery so it's at least 4 times consumption. As long as it's more than 2 times consumption, you're safe. But as soon as delivery drops below twice consumption, that's when you get anaerobic metabolism, lactic acidosis, and so on. The major controller of oxygen delivery, of course, is blood flow, but right after that comes hemoglobin. And somehow, right now, we're in this era when it's okay to be anemic, and in fact, if you're really sick, you ought to be really anemic, which doesn't make any sense at all to me. So I always say the optimal hemoglobin is what yours is. It's about 15 grams %, and if your patient's really sick, that's where it ought to be.
We're going to talk about future predictions a little bit later, but I remember Dr. Colabo wrote an editorial in the 70s about how membrane oxygenators would replace ventilators someday. Do you remember that theme back then?
He did. He talked about the membrane lung replacing the ventilator, but he didn't mean across the board. Actually, there's a lot of research now on ventilator pressure and what level of plateau pressure injures the lung. And Ted Colbo did these studies in the 70s. The answer is 22 centimeters of water in sheep. It's the same in humans. So if you ventilate patients but never raise the ventilator pressure greater than 22, those patients will do remarkably well. You won't add to their injury by baro or value trauma. A lot of good docs have forgotten that over the years. Now we're coming back to it now. So you use pressure-controlled ventilation at a pressure of about 20.
Our friends at the American Academy of Cardiovascular Perfusion invited you on the anniversary of the 50th anniversary of cardiopulmonary bypass to come to the Academy meeting and talk. And they asked you to predict the next 50 years. Do you remember that exchange? Or
I do, yeah.
The Academy's always a lot
Although
of
I
fun.
can't remember what I said.
Yeah, well, we have that for you. So I'll give you a couple of seconds to read it ahead. So looking at some of your predictions, this is back in 2003. There are several of them here. The folks here can read them, but why don't you just briefly share what you were thinking at the...
Well, this was 2003 was at a time when most intensivists around the world thought this was all nonsense. You certainly wouldn't want to do this because it was difficult to do, a lot of complications, a lot of problems, and in my unit, no one ever dies anyway, so why would anyone ever want to do this? So 2003 is important because that all changed in 2010. So what you're all doing now is the result of the H1N1 flu epidemic, when everyone said, oh gosh, we're going to have to learn how to do this because it works so well in those patients. And two companies from Germany developed ECMO machines. Prior to that, there was no such thing. So you had to go down and take used things from the OR, something from your garage, and hook it all together, and that was the ECMO machine. But both McKay and what's now called Novolung developed devices that were actually intended for long-term use, had to have solid membranes and stuff like that. So in 2003, this was a pretty wild prediction at the time. We'll use this routinely for cardiac failure or respiratory failure. We talked a lot about fluorocarbon ventilation, which has not become standard, but it will. So once we get through some FDA hurdles, you'll be filling the lungs with fluorocarbon in your respiratory failure patients. And of course, you can just plug in a module now for renal failure. Sooner or later, you'll be able to plug in your liver failure module to your ECMO circuit.
I'm going to take a brief break. I'm not being rude. If you want to submit some questions to Dr. Bartlett, use the ARS, and I'll keep an eye on it up here, and we'll have a little bit of time here in a few minutes for your questions. Did you see this coming?
Didn't look like your prediction was all that wild.
Yeah, well, again, you can see this all happened in 2010. And I know that many of you as perfusionists are getting involved with ECMO teams, many of you running ECMO teams, but I dare say there are only a handful of you who were doing this prior to 2010. And it's much easier nowadays to start an ECMO team and have it work right from the beginning. So the application of this, these are data from the registry,
Yes.
but it was just only being done in a few research centers for many, many years. And then once really good devices became, they're much safer, much simpler to use, then you could use the technology routinely and really test it.
here are some more predictions from that address.
Well, anticoagulation is the interesting thing. As I said, we started out by measuring whole blood ACTs, and with heparin you can measure a dozen other things, some of which are important. Antithrombin 3, 10A I hate. I'm sorry you put it on the exam. Because what it tells you is how much heparin in the blood, but you don't care how much heparin is. What you care about is how long it takes the blood to clot. So whole blood measurements are really what's important. So thromboelastogram or whole blood ACT is what you use. I was watching the session just before this one. It was a very nice session about ORs and doing timeouts and stuff like that, and then commenting on the capabilities. But every case had to do with, did you measure the ACT? So it's
That's right.
nice to see that we're still at that very elementary level.
Haven't moved on, have we?
So the reason that prosthetic devices clot is because platelets stick to the surface, and the platelet becomes activated, and then in turn activates the clotting cascade, so fibrin is formed. But if the platelets don't get activated in the first place, then you don't need to worry about preventing fibrin formation, which is what heparin does. So the reason this is really 2003, we've been working on that ever since, trying to make plastic that prevents platelets from sticking to the surface. And we're getting close to that. It turns out that the way your normal endothelium prevents platelets from sticking to your blood vessels is by generating nitric oxide, that magic molecule. And so if you can make plastic that secretes nitric oxide, you can prevent the platelets from sticking, and that should be the ideal non-thrombogenic surface. And we're very close to that now. We're at the point where we can put lambs on ECMO for a week with no systemic anticoagulation and no loss of platelets and no loss of platelet function and no clotting in the devices.
There's been a time when you've been frustrated with the perfusion community.
Well, it is true that the perfusion community as a group not only ignored but didn't want to get involved with ECMO in all those early years up until 10 years ago, basically. If there were a few perfusionists, like Jeff, like John Tomasian, like Nick Haydick, others who were instrumental. Linda, I don't know if Linda's in the audience, but in general, perfusionists didn't like that, for good reason, because what you're good at is you go to the OR, you can run that system. If no one ever says a question, you've done it perfectly, the patient does well, you come off bypass, they're great, takes a couple of hours, and that's what you do. So the idea of going to the ICU and sitting there with a system that's kludged up from someone's garage and then hooking it up and sitting there for days at a time to watch it just to do ACTs was not interesting to most perfusionists. Correctly so, it really wasn't what you did. So that in the very early days, we had the perfusionists I mentioned who were crucial to our team, but we learned that we had to train nurses to be perfusionists, or we had to train respiratory therapists to be perfusionists, or we had to train perfusionists to be nurses and respiratory therapists. Mm-hmm. So we have been doing that since the early days. Our first ECMO team I intentionally had a perfusionist and nurse and a respiratory therapist to see how it would work. And you imagine they all had to learn the skills that the other person had. And this is what a time when you had to be at the bedside literally 24/7. You had to get someone to cover you if you took a bathroom break, because something could break, the whole system would blow up or something. But while we got started, there was a group at Columbia where Charlie Stoller was developing the neonatal team, and he said, I'm going to go with an all-perfusionist team. So that's great. There's a guy named Mike Klein who ran the ECMO program at Detroit Children's Hospital, where money is a big problem. He said, I'm going to go with just respiratory therapists. I'm going to train them how to do it. And at our team, we had equal numbers of those special, just to see how it would work. Turns out it all works well. So once people learn the basic physiology, they can manage it much easier now, because the bedside nurse, who has to be there anyway, can now manage the ECMO patient almost all the time with someone around who can troubleshoot it if they need it. And most of the current ECMOs that's done around the world, again, developed in the last 10 years or so. And wherever you go in the world, the perfusionists are the ECMO specialists. So in the United States, it's still a little bit unusual to have nurses who are trained as perfusionists rather than the other way around, which I think is good. I'm delighted that ECMO is now an exciting part of the perfusion community. That's the way it should be.
As more perfusionists are becoming more engaged with ECMO, with the emergence of ECMO across centers and bringing new centers aboard, how do we overcome some of these quote unquote turf battles and be able to work as a multidisciplinary team together at the side of the patient?
Yeah, of course, you're going to have turf battles because you work with cardiac surgeons. I'm sorry, I'm one, but it really becomes an intensivist thing, whether it's neonatal or adults or whatever. But as you all know, if you're doing this, you have to get all those people involved. Someone was describing this yesterday, saying that you need to have everyone in the hospital involved, someone you might not think about, the cardiac cath guy, the blood bank person, the palliative care for neonates, the geneticist. All those people have to be involved in this team. But the key to it, as you all know, is to have everything controlled by protocol. So there's a way we do everything, right or wrong. We always do it that way. And then you revise the protocol every 6 months or something like that. So that's where this exam that Jeff and your team has put together is going to be so valuable, because right now there's no way to measure that or quantitate it or to say, I'm really good at doing ECMO. I don't know what that means. And you might be really good at doing ECPR, but you've never taken care of a neonate. How do you deal with that? So you're taking the lead in making that happen, and I say good for you. It's really very well done.
One of the questions from the audience is, how can we work better with ELSO? What's the secret sauce to?
I started ELSO in 1989, but over the years I've gotten more and more in the background, have other people running it, and they're very good and they do a good job. But the goal of ELSO is just like the goal of AmSect. When you run those goals, we want patient safety, we want to do things well, we want good results, and have people who are really good at doing that. And that's what ELSO is also about. So I've always said that ELSO and AmSect and SCCM and the Cardiac Society should all be working together at this goal rather than trying to do it separately. And Jeff's exam is a great example, which AmSect offered to ELSO. How'd you like to join in this with us? The officers at the time turned it down. I thought that was really stupid. But good for you for getting it going, and eventually it'll all be working together. ELSO is, as you can see, it's only about ECMO. So it's this little tiny niche technology. It's a little bit of what you do. It's a little bit of what intensivists do. It's a little bit of what neonatologists do. And so what ELSO can do is provide the registry. That's the most important thing we've done. Here's how this technology is growing. And also education. So if you're going to do this, here's some recommendations about how to go about it.
Thank you. There was another sneaky prediction in here that cardiac surgery is going to shrink, and it shrunk 25% in the next 15 years.
Yeah, it'll continue to shrink, but the same is true of surgery everywhere. It's all become minimally invasive and done through telescopes and little tiny catheters. But that's the future of cardiothoracic surgery, going to be heart and lung transplant. There's no way to do that through a little tiny hole. So I still like there's a role for surgery, there's a role for cardiac surgery, there always will be, but it's going to be more and more VADs and transplants rather than fixing valves and doing
Patients
coronary
are sicker.
bypasses.
Yeah. So we scored you on the 2003 article, and you got an A- for predicting the future.
Oh, good. Thank you.
Thank you for doing that back then, and it's nice to reflect back on our predictions. We still have a long way to go, of course. Questions from the audience? Do we get any more that...
Here's a question. Outcomes reported in the ELSO registry haven't changed dramatically in adults over the last 20 years. Is doing sicker and sicker patients the right approach?
The key for adult respiratory failure is all about detecting the high-risk patient early on and then going to ECMO as soon as you're clearly in a very high mortality risk group. If you want to learn more about that, you should read the EOLIA study. It's a prospective randomized trial of ECMO for ARDS. It was conducted in many centers, mostly in France. Very good study, but it all boils down to having a way to measure mortality risk after having done all the other things you might imagine, nitric oxide, prone positioning, blah, blah, blah. And if none of that is working, that's the time to go to ECMO for those patients.
We have another one. We speak about the importance of finding joy in work. What brings you great joy in your work?
Well, nowadays, it's just getting up in the morning. You know, I'm 80 years old, so I'm quite pleased. I'm still very active in the lab. We run a big lab that's studying the next generation of this technology, artificial placentas and wearable devices and things like that. So that's a lot of fun. I have fun doing that, but I do have a fairly active clinical practice, but it just is all by telephone. So I'll get a call about once a week, probably from some of you, from somewhere, someone in the world, saying, I've got this problem, it's not working. And my first question is, what's the hematocrit? And the answer is 28. I said, okay, give them 4 units of PAC cells and call me if there's a problem. I never get called.
You get called back? We accepted one of your lab techs into our perfusion education program.
Yes.
She was...
Mackenzie Hayes, you will get to know her. She'll be president of this organization in about 20 years.
Although she's been with John Tomasian for 2 years.
Yeah, trained with John
We're going to have to
personally. So she's like a lot of, perhaps like a lot of you, but certainly we have 100 undergrad students that work in my lab, and they're all pre-med. They want to get into med school. That's what their goal is. But along the line, there are people who say, you know what, I'd rather do this. And Mackenzie was in that track, but she just fell in love with perfusion. She said, this is really great. John's there to say, okay, here's how you can do this perfectly in pigs and sheep. And she got excited about it. So fortunately, they accepted her at the Syracuse program, and she'll be wonderful.
You've mentored more than a dozen PhD projects, though, haven't you?
Oh yeah, lots of fellows.
Jeff, we have about 2 minutes.
Okay, perfect. I'd like to take a second. Bob Groom is back home watching this. David and I are just the pretty talking heads up here with Dr. Bartlett. Bob Groom scripted this, wrote it, researched it, and Our Words has been his organization. Bob had to go home to be with his mom as she passed, and he would love to be here, and he respects you a lot, and so this work came from that. 6 months ago, I called Dr. Bartlett, and I told him what we were up to, writing an exam, and I interrupted his vacation at the lake, but he talked to me anyway. And we talked for a few minutes, and he actually surprised me that you were supportive of our project.
Totally so. Yeah.
I was pleased by that, so I felt better about that. And you actually were happy that we were going to help motivate ELSO to move on too and get their act together. And we've elicited 2 editorials out of them in the last 4 months in critical care medicine. That's good reading.
Yeah.
You took the exam.
Yes.
And
Congratulations.
And I passed it.
Your
Thank you.
official
That's great.
adult certified ECMO specialist.
There you go.
If you want me to ship that to you, I'll ship it to you.
Oh, that'd be great.
You
Well, actually,
earned that. You earned
I
that
can,
the hard
I'll
way.
carry it. I don't want to break it, but I think I can carry it.
I was so pleased when you took that exam. All the subject matter experts were, how did you get him to do that? And I said,
Oh, I
just
thought
stood back and
it's really important. But if I'm going to comment on it one way or another, then I should take the course and take the exam, which is why I did this. But it's marvelous. It's exceptionally well done. I didn't answer all the questions correctly, I should tell you. So, that's because those of you who took the exam were in a nice room here in the hotel with a proctor and a moderate amount of pressure. I took it with a glass of wine and playing music in the
might be
background.
the
So
right way. Huh? Thank you very much.
Well, we want to
thank you.
thank you for being here today, and on behalf of the entire society, I can tell you that I think this luncheon will be a memorable one for us, and your contributions to ECLS. Thanks to you, a lot of us have sleepless nights at the ICU beds, but we've been able to watch the miraculous use of ECMO. So thank you so much for being here.
Thank you. Thank you all. You're very gracious. Thank you. Thank you. I'm certified.
You can go out and do ECMO now.
That's right. Thank you.